Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra, di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione, tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or their family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
So I am a full-time intensivist and proud to be one. We're all working together in a multidisciplinary fashion to fight COVID-19. Together, we are intensive care medicine.
Hello, I'm internal medicine specialist and I'm proud to be an intensivist. We intensivists are working hard to fight for COVID-19. Together, we are intensive care medicine. Thank you.
I am the editor of Intensive Care Medicine Journal and I'm proud to be an intensivist. We are working together to fight COVID-19 and to take care also of non-COVID patients. Together, we are intensive care medicine.
I'm a nephrologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hi. Hello. My name is Ludmila Rajar, and now I'm really honored to be part, to co-share this honored webinar from Ezekin, launched by AOP Orphan about management of septic shock, looking to the overview of vasopressors. I'm honored to co-share this webinar with my colleague, Professor Doru Sandesc from Romania. Thank you. It's a pleasure to co-share with you, Professor Doru.
Thank you very much, Ludmila. Hi. Hi, everyone. For me also, it's a great pleasure and honor to participate at this very interesting webinar from 3 continents. All I can dream is that next time we will be together, no matter in which continent, and we will have better times. So thank you very much. And we will start the webinar with the first speaker, who is Dr. Jacob C. Jenser from Mayo Clinics, Rochester, Minnesota. He is first full-time dedicated cardiac intensivist and director of cardiac intensive care unit research in this hospital, and will present the first conference with the topic Vasopressors in Severe Septic Shock, a general overview. Dr. welcome.
Hello, everyone. Welcome. I hope everyone's staying safe in these difficult times we face. As was stated, I'm Jake Jenser from Mayo Clinic, and I'm here to speak with you about vasopressors for septic shock. I have no relevant financial disclosures for this presentation. So when I think about vasopressors, I classify all drugs that are designed to increase arterial pressure by peripheral vasoconstriction as vasopressors. And I break vasopressors into 2 basic categories. The first category I call pure vasoconstrictors. And these are drugs that really only affect the peripheral vessels and do not have direct cardiac inotropic effects. Examples include phenylephrine, which is a pure alpha-1 agonist, as well as vasopressin and angiotensin II. And these drugs have an important advantage in that they have no direct cardiac toxicity, although there have some limitations that I'll discuss. More commonly, we use catecholamines, which sometimes I also call inoconstrictors, because in addition to causing peripheral vasoconstriction, they have inotropic effects by activating beta receptors. And these beta inotropic effects both increase cardiac output and heart rate, which might be beneficial, but also predisposed to potential for cardiac toxicity, especially higher doses. And we know that drugs like epinephrine and dopamine have much stronger beta inotropic effects than norepinephrine, which predominantly has beta inotropic effects at higher doses. So when we think about the peripheral vessels themselves, it's important to realize that all of the major vasoconstrictor mechanisms seen here on the top of the figure are mediated through the same second messenger signaling cascades, culminating in an increase in cytosolic calcium in the vascular smooth muscle. And the most common, of course, is the alpha-1 receptor, which is activated by all of our catecholamines. But the same mechanism is activated by vasopressin receptors and angiotensin II receptors. But what's most important to realize is that adequate amounts of vasopressin, angiotensin, and glucocorticoids are required for normal alpha-1 adrenergic receptor function, and that alpha-1 adrenergic receptors don't work normally in the setting of low pH conditions. And these are the underpinnings of severe and refractory septic shock. So when we think about refractory shock, meaning patients who are not responding normally to vasopressors, it's important to understand that there are two dominant mechanisms involved. The first is related to a variety of metabolic abnormalities that can interact to cause alpha-1 receptor desensitization through a number of mechanisms. Examples include the systemic inflammatory response, as well as acidemia, lactic acidosis, et cetera. And these can cause dysregulation of nitric oxide metabolism and accumulation of reactive oxygen species, both of which can act through a number of mechanisms to impair the vascular responsiveness to catecholamines. But the other major category of mechanisms is related to absolute or relative deficiencies in vasopressin, angiotensin II, and corticosteroids. And it's important to remember these because these are potential treatments you might use for a patient with refractory shock. Now, when we think about toxicity of vasoactivations, it's important to remember that, like all drugs, vasopressors have a better safety profile at lower doses. And as higher doses are given, the potential for toxicity emerges. So when you see that a patient is requiring high doses of catecholamines, this implies that their vessels aren't responding normally to these drugs, predominantly due to alpha-1 receptor desensitization and related mechanisms. And as you use higher and higher doses of catecholamines, you can have off-target cardiac toxicity due to the beta receptor activation. Now, any vasopressor can cause excessive vasoconstriction in off-target vascular beds like the skin and gut, potentially causing tissue ischemia at high doses. So in an ideal world, we would use drugs with different mechanisms at lower doses to maximize both the safety and the efficacy. And some people have termed this the vasopressor toolbox approach. But the final bullet point is that if a patient is not responding well to an initial catecholamine, or if they're having toxicity from that drug, you should add a second agent, predominantly a catecholamine-sparing drug, to improve the clinical status. Now, this is a curve showing the association between vasopressor doses and mortality. Now, these data are specifically from my cardiac intensive care unit, but you will see the exact same curve in any other intensive care unit, in any type of shock, septic, hemorrhagic, et cetera. So when we see mortality goes up dramatically as vasopressor requirements increase, and many people use vasopressor requirements as a simple metric of shock severity. And as you can see, patients that are requiring more than 0.3 mics per kilo per minute of norepinephrine are at very high risk of death. And once you get to the level of 0.5 mics per kilo per minute or above, the majority of patients are going to die in the hospital. And so this has been a threshold used to define refractory shock. So before I talk about rescue therapies for severe septic shock, I wanted to talk about the evidence supporting first-line vasopressors for sepsis. And I'm going to tell you that norepinephrine is the first-line vasopressor drug, not just for septic shock, but for most forms of shock, including cardiogenic shock. The Surviving Sepsis Campaign guidelines have recommended norepinephrine as the first-line vasopressor for septic shock for several years. And I'm going to show you evidence supporting this recommendation. We know that norepinephrine has better outcomes and fewer adverse events than dopamine. It has similar mortality, but fewer adverse events than epinephrine. It has similar overall outcomes, but a lower drug cost than vasopressin when used as initial therapy. And I'm going to draw a distinction between initial therapy and rescue therapy when talking about vasopressin. And I typically don't use phenylephrine as a first-line drug simply because there are no large-scale outcome randomized trials showing its safety and efficacy. So the main study that showed the importance of norepinephrine as opposed to dopamine was the SOAP-2 study. And this, along with the totality of evidence, has led me to conclude that dopamine should not be used as a vasopressor, either in septic shock or in cardiogenic shock. And there are a number of reasons for this. One important point is that many patients clinically will fail dopamine even at maximum doses because of its indirect effects and poor efficacy. In the SOAP-2 study, we saw twice as many arrhythmias with dopamine, and you can see from these survival curves that there was a suggestion of possibly better survival with norepinephrine that didn't quite meet statistical significance. But when you combine this study with other studies in a meta-analysis, we see that patients who get norepinephrine have a lower mortality than those who get dopamine. With epinephrine, several studies have shown similar mortality results when compared to norepinephrine. So it's not unsafe to use epinephrine, but we do see more off-target side effects with epinephrine, more tachycardia, lactic acidosis, hyperglycemia, and arrhythmias. So what about catecholamine-sparing vasopressors? Just to be clear, I'm talking about vasopressin and angiotensin II. And here are the typical dose ranges. Now, both drugs can be titrated, but in my experience at many hospitals in America, vasopressin is given at a fixed dose and often is not titrated. Now, this is not the only approach, but it is a common strategy, and it has important limitations that you should be aware of. Now, both of these drugs might be associated with lower mortality in specific patient populations. They also are associated with less kidney toxicity, particularly in the setting of renal replacement therapy. And vasopressin in particular has been shown to have a lower risk of arrhythmias because it doesn't have adverse direct cardiac toxicity. Now, both of these drugs have important limitations. They both can cause excessive vasoconstriction. Vasopressin in particular can be associated with mesenteric skin and potentially coronary vasoconstriction. And angiotensin II is more costly and has been associated with an increased risk of thrombosis. Now, both of these drugs have a fairly rapid onset, but vasopressin has a little bit longer half-life and therefore takes longer to reach steady state. Most patients are going to respond to either of these drugs, but not everybody. And so these are really good drugs for patients that are not responding well to catecholamines. Now, the data for vasopressin added to catecholamines comes predominantly from the VAST study. And as you can see from these survival curves, there is the suggestion that patients who got vasopressin did better, although again, did not reach statistical significance. When they did secondary analyses of the VAST study, what they found is that adding on vasopressin to reduce norepinephrine requirements was associated with lower mortality in patients that had less severe shock at baseline and those who also got corticosteroids. And again, vasopressin was associated with a lower risk of AKI. But what's interesting is that when they did a secondary follow-up study called VANISH, using either norepinephrine or vasopressin as initial therapy for septic shock, they really didn't show any significant differences in their primary outcomes, including mortality. There may have been a reduction in some AKI markers, but again, really not a strong signal. And when you combine all the vasopressin studies into a meta-analysis, there was no overall reduction in mortality. But it's important to realize that this meta-analysis includes studies using vasopressin in different ways. And I think vasopressin is better when given as a second vasopressor to reduce catecholamine doses, and I'll show you some evidence for that later. Angiotensin II, again, is the most recently introduced of these drugs. And importantly, it was studied against placebo in patients with severe vasodilatory shock who were requiring at least 0.2 micrograms per kilogram per minute of norepinephrine or equivalent. And as you can see from these curves on the bottom, specifically the blue angiotensin curve, when you start angiotensin, the blood pressure goes up and the vasopressor doses go down. And this is a consistent finding, although patients who are on very high initial norepinephrine doses were less likely to respond. And although the study wasn't powered to detect a difference in mortality, you can see that the trend is in favor of lower mortality with angiotensin II and was not associated with an increase in adverse events. And secondary studies have shown that patients who have high renin levels or who have severe AKI requiring dialysis appear to have a substantial benefit when they get angiotensin II. So these are populations to target. So how do I use vasopressors in septic shock? Well, I try to target the vasopressors to the severity. So for patients with mild septic shock, which I'm defining as a norepinephrine requirement less than 0.1 microgram per kilogram per minute, really all I use is norepinephrine. I don't typically add secondary vasopressors in these patients, although I make sure that they have adequate antibiotic source control and fluid resuscitation. When patients are not responding to these low doses of norepinephrine and they're needing higher doses, maybe up to 0.2, I ask myself why the patient isn't responding well. I want to make sure that they don't have some concomitant cardiac dysfunction, possibly a mixed cardiogenic septic shock state. And I also want to make sure that easily reversible metabolic abnormalities have been addressed. Some providers will start a second vasopressor in this norepinephrine dose range, although I typically don't. And it's not wrong to do it, but it's just not my personal strategy. Once patients get to a more severe septic shock, though, where they're requiring 0.2 micrograms per kilogram per minute of norepinephrine or higher, this is the point where I'm usually going to add a second vasopressor. And in most cases, I'll also consider use of stress dose steroids. And I want to add my second vasopressor before patients get to what I term resistant or refractory septic shock, which would be patients who are requiring greater than 0.3 micrograms per kilogram per minute or greater than 0.5. because we know that the mortality is higher and these patients are less likely to respond to rescue therapies. So which second vasopressor to add? Well, the real question is, do you want to add more catecholamines, such as epinephrine, or do you want to add a catecholamine-sparing agent? In my personal opinion, adding dopamine or phenylephrine when a patient is failing significant doses of norepinephrine is not really a great strategy, as patients often don't respond well. Now, epinephrine has important strengths and weaknesses like all drugs. Because of its strong beta inotropic effects, it can increase the cardiac output, which can be advantageous, for example, if the patient has inappropriately low heart rate, cardiac output, or a venous oxygen saturation. But it is associated with significant cardiac toxicity with myocardial ischemia, arrhythmias, and tachycardia. And it will cause increases in the lactate and glucose levels that may be problematic. It also has not been shown to be associated with lower mortality when used as add-on therapy. So it is not my first-line strategy, but it is appropriate for some patients. On the other hand, vasopressin and angiotensin II have similar hemodynamic effects and are essentially free from major cardiac toxicity, which is important. They also will not cause these off-target metabolic abnormalities. And as I showed you, they may be associated with better outcomes when added on to catecholamines. Vasopressin in particular can be useful when the arterial pH is low and catecholamine receptors are not working normally. And I already mentioned the renin levels. And so vasopressin, importantly, the dose labeled is up to 0.03, although higher doses have been used in the literature and in clinical practice. Now, this is a nice analysis by some of my colleagues where they looked at second-line vasopressors. And they said, is it better to increase the norepinephrine dose to add vasopressin or to add angiotensin II? And as you can see here, although vasopressin was associated with a little bit higher drug cost, it was associated with lower mortality, and therefore it had better outcomes, and the incremental cost was modest. And I want to really emphasize that drug costs are not the dominant thing to keep in mind when selecting drugs. And they vary very much between different institutions and different countries. So I think that in many countries, the acquisition cost of vasopressin is actually lower than it is in the United States. And so I think it's best to use the drug that's going to provide the best outcome for your patient, because if you improve survival and shorten ICU length of stay and prevent kidney injury, that's almost always cost effective. So how do I individualize my second-line therapies? So again, I'll use epinephrine in selected patients, predominantly those where I think there's a mixed shock component with inappropriately low cardiac output, a low SpO2, or inappropriately low heart rate. Now, just because a patient has left ventricular dysfunction or myocardial abnormalities on echocardiogram, that doesn't mean they need inotropes. But certainly we know that many patients with sepsis will have either pre-existing cardiomyopathy, septic cardiomyopathy, or in some cases, cor pulmonale from lung disease. And some of those patients do need inotropic support. And we often will use dobutamine, but that can cause excessive vasodilation, which can aggravate the problem. And so epinephrine can be a nice alternative in those patients. But you always have to be concerned about myocardial ischemia and arrhythmias with epinephrine. And again, if someone has severe lactic acidosis or uncontrolled hyperglycemia with diabetic ketoacidosis, epinephrine is usually not a good drug in those patients. For most patients, my default drug is vasopressin, particularly if they have a high heart rate or arrhythmias, because vasopressin can help those problems. Again, if the pH is low, vasopressin might be a little more effective. And vasopressin is a great drug for post-cardiotomy vasoplegia syndrome, which is a non-infectious vasodilatory shock phenotype that we see often in the post-operative state after cardiac surgery. But again, if a patient has a mixed shock state with low cardiac output, severe left ventricular systolic dysfunction, vasopressin can aggravate that and might not be an ideal drug. Likewise, if I think the patient has gut ischemia, I tend to avoid vasopressin. Angiotensin II is a very good alternative drug. I typically use it when a patient's not responding to vasopressin plus catecholamines, but it can be very, very effective for selected patients, especially those with high renin levels. The problem is that in most hospitals, renin levels don't come back quickly, but renin is a very good marker of perfusion. And if a renin level is high, that implies the angiotensin II level is low, and therefore giving the drug can be helpful. We know that there's a higher rate of recovery of AKI when patients are given angiotensin II, and so if patients are on dialysis as a result of AKI, I definitely consider angiotensin II. And again, it's really my go-to move for resistant or refractory shock. So here's some clinical pearls. So if the catecholamine doses are rising rapidly, the first thing I always remind people is make sure you know what you're treating. Are you confident that this is septic shock? Are you confident that you have source control and appropriate antibiotics? Is there any chance that there is a different type of shock that is not immediately apparent, cardiogenic or hemorrhagic? It's also important to identify treatable and reversible metabolic abnormalities. Although the evidence supporting alkali therapy for treatment of acidosis is controversial, in my cardiac population, I find that many patients do not respond well to inotropes and vasopressors with even moderate acidosis. I also am a big believer that ionized calcium should be normal to improve vasopressor responsiveness. And if you're seeing rapidly rising catecholamine doses, that tells you catecholamines aren't working, and it's a good cue to add a catecholamine-sparing vasopressor. And my practice is that when I'm adding a second vasopressor, I add corticosteroids. My interpretation of the steroid literature is that corticosteroids consistently improve blood pressure and vasopressor responsiveness, but it's hard to predict who will benefit, so giving them routinely is my practice. We also know that corticosteroids are not associated with higher mortality in broad populations and may in fact reduce mortality in highly selected patients with very high degrees of critical illness, especially with ARDS. And we know that corticosteroids do cause predictable side effects, but those typically are not severe. It's also important to remember that catecholamine-sparing vasopressors, they don't always work because they're predicated on the idea that patients are deficient in those signaling molecules. And so if a patient has adequate vasopressin levels, then giving more might not raise their blood pressure. So if you start one of these drugs and the patient doesn't respond, you don't need to continue it. And in fact, you should switch to the other drug. Now, once you're finally successful and the patient's shock gets under control and they're in the recovery phase, typically we start peeling back vasopressors. And my usual approach is last on, first off. So if I've started angiotensin as a bailout therapy after failing vasopressin and norepinephrine, I'll typically wean that off first if possible. But what's interesting is that although I used to stop the vasopressin before I stopped the catecholamines, there's some newer evidence that suggests that if you continue the vasopressin while you wean the catecholamines off, and then gradually wean the vasopressin after that, that the risk of recurrent hypotension is actually lower. So that's a strategy I've been using more recently. So to put this all together, with early septic shock, you want to identify and treat the underlying etiology. You want to do appropriate fluid resuscitation guided by optimal measures of fluid responsiveness. And for most patients, you start with norepinephrine and stick with norepinephrine as long as you're not needing high doses. But once you have severe septic shock requiring more than 0.2 micrograms per kilogram per minute of norepinephrine, you want to identify and treat any secondary contributing causes, make sure the patient's not hypovolemic, acidemic, or hypocalcemic, and then use that rational combination vasopressor therapy, adding a second vasopressor. In most cases, this is going to be vasopressin, but certainly if the patient appears to have borderline or low cardiac output, epinephrine is a reasonable alternative. But then if one or both of those drugs are not working, you should rapidly go to angiotensin II, especially if you're needing more than 0.3 of norepinephrine after you add vasopressin. In this stage, I'll, again, usually add stress dose corticosteroids once I'm on a second vasopressor. Now, if this all doesn't work and you're having progressively rising vasopressor requirements so that you're on more than 0.5 mics per kilo per minute of norepinephrine despite being on vasopressin plus or minus epinephrine and angiotensin II, this patient is very likely to die if you can't identify a reversible etiology. It's important to think about whether a secondary complication could have occurred. An example would be a patient who has abdominal sepsis and has received a lot of fluid resuscitation and now has developed abdominal compartment syndrome. And that is potentially a treatable etiology of refractory shock. There are many other examples, as you know. But if you can't rescue the patient, then it's very hard to get them through this type of severe illness. In some cases, you think about ECMO, extracorporeal support, for these types of refractory septic shock if there's a reversible etiology. And there are a couple of last-line bailout therapies that people talk about. Examples would be methylene blue and hydroxycobalamin, which antagonize nitric oxide signaling. And although these drugs definitely can raise the blood pressure, the concern is that nitric oxide is necessary for normal vascular function and distribution of blood flow within the organs. And so if you antagonize it excessively, you can raise the blood pressure but worsen perfusion. And prior studies looking at nitric oxide antagonists in septic shock have actually shown increased mortality. So I really don't use these drugs unless it's really a last-ditch effort. So I really thank you very much for your attention. And I think we're taking questions electronically, and I'll be happy to answer those at the end.
Thank you very much for this very interesting presentation, Dr. Gencer, and I invite the participants, the audience, to send questions that will be discussed at the end of our webinar. So please, Ludmila, introduce the next speaker.
Yeah, I have the pleasure to introduce our next speaker, Professor Dr. Arthur Van Zanten. Professor is the internist, intensivist, and chair of the Department of Intensive Care and ICU Research in Geodès Valley Hospital in Eds, and professor of nutrition and metabolic stress by special appointment at Wageningen University and Research in the Netherlands. Thank you very much, Professor Arthur. You have 20 minutes to bring to us all your great experience in the field, and in the end, we'll have lots of questions for you. Thank you very much, Professor Van Zanten.
Thank you very much, Ludmila and Dorel, for the kind invitation. It's an honor to speak during this ESICM webinar series. So I will address some aspects of the clinical practice with second-line vasopressor, mainly vasopressin, and talk about the benefits and some COVID-19 cases. So first of all, I have to disclose that they received several speakers' fees from several companies, especially also by AOP Orphan or Amomed, the company of vasopressin, and I'm the chair of the sepsis guideline program in the Netherlands. So we already heard that, of course, patients on high levels of vasopressors have high mortality rates. And of course, we immediately will say this is due to the severity of illness. However, more and more information has been published in the literature about harmful effects of catecholamines. So it can be injurious to the myocardial cells, induce oxidative stress, and also have immunomodulating effects. We know, for instance, from recent studies that when we use high dose of norepinephrine, this may dysregulate the innate immune system. And we all know that in the late phase of recovery of sepsis, there can be sepsis-induced immunoparalysis, inducing secondary infections, and by this impairing the final outcome of our patients. So it's interesting to know that, for instance, the vasopressin doesn't have this effect. And we heard about that there are more ways to get vasoconstriction. So we can use noradrenaline or norepinephrine, but we can also use angiotensin or vasopressin. In my talk, I will mainly focus now on the role of vasopressin in vascular smooth muscle cell contraction. We know also that in the late phase of septic shock, there is a rather relative vasopressin deficiency. So maybe vasopressin not only has an effect on vasoconstriction, but also solving the problem of vasopressin deficiency. And when we look at vasopressin, it has, it's arginine vasopressin is available now as a drug. It's typical like the human vasopressin. It's an antidiuretic hormone, and it's a naturally produced human hormone for raising the blood pressure and inducing water retention. And mainly there are three receptors involved here. The V1 receptor inducing vasoconstriction, the V2 receptor inducing water retention in the kidney, and the V3 or V1b receptor leading to the release of ACTH from endocrine cells, as you all know, which will stimulate cortisol release from the adrenal gland. And this is also very important during septic shock. So at higher levels, the V1 activation and the vasoconstrictive properties of vasopressin are predominant. But at low plasma levels of vasopressin, so less than 10 picomoles per liter, arginine vasopressin V2 receptors antidiuretic actions are predominating. So that's important. So in high dose, it's just a vasopressor. Now we heard about refractory shock, septic shock or vasodilatory shock, but There is not a good definition for this, and some say it's 0.5 micrograms per kg per minute. In our hospital, we use 0.25 micrograms per kg per minute, because we know from that point up, as we heard before, mortality goes up rapidly, and we believe that adding a second vasopressor is helpful in this kind of patients. And of course, it's important to give optimal fluid resuscitation and be aware of enough flow, so cardiac output, so you have to do measurements for this. We heard about the VAST trial comparing norepinephrine with norepinephrine plus vasopressin. And it was a negative study for the primary endpoint mortality, but there was maybe a trend of a slightly better survival probability in vasopressin patients at 90 days. The p-value was 0.10, but that's considered a negative study. But in this study, we saw that the effect of adding vasopressin had a marked norepinephrine sparing effect. So we can reduce the doses of norepinephrine, and when we believe that this overstimulation with catecholamines and this immunoparalysis, well, has importance, this could be helpful for our patients to add this second vasopressor. And then there came, post hoc analysis, reanalysis of the data sets, and it was striking to see that from this trial, when we separate the groups in patients with lower Apache 2 scores, so lower shock severity and lower lactate levels, that in these patients, there was a significant reduction in mortality by the effect of adding this vasopressin to the catecholamines, the norepinephrine in the study. So maybe we should not wait till the patient is in such a refractory shock with such high levels of norepinephrine that it's only, not working anymore. So maybe we have to add vasopressin earlier. Some time ago, we still use Terlipressin, because in the Netherlands there was not an availability of artipressin or vasopressin, so we use Terlipressin. But the problem with Terlipressin, there's some literature on its use in septic shock, and this is a study I show you here, that there was no difference in mortality. There was no difference in the course of the SOFA scores of the patients during the first week of ICU admission, but there was an increase in serious adverse events, mainly ischemia, digital ischemia, but also some splentic ischemia. And the difference between Terlipressin and artipressin or vasopressin is the half-life. So Terlipressin has a long half-life, and vasopressin has an effective half-life only 10 to 20 minutes, so it allows more for an on-off effect. So you give it in a continuous infusion, and when you stop and there is a negative effect, this effect will disappear very quickly over minutes. And it takes also a short time to see the effect, as was already alluded to by Jacob in the previous presentation. There is some data from meta-analysis available. This is by McIntyre, published in JAMA, showing that the incidence of new onset atrial fibrillation in distributed shock is about 23% less when catecholamines are combined with vasopressin, as you can see in this forest plot. There was also a lower mortality in this study, 11% lower, but we have to be careful with the quality of the studies that led to this conclusion. And there was a trend towards less use of renal replacement therapy in septic shock in this patient, but this effect was not significant. It was about 24%, but the p-value was non-significant. There was more ischemia in the patients treated with vasopressin, especially more digital ischemia, so toes, fingers, nose, ears, and that kind of side effects. In our ICU, we don't see it so much, and I think it's important that it may has to do with suboptimal fluid resuscitation of the patient. So, of course, when you increase the vasopressor in a patient without optimal fluid status and without the optimal cardiac output, you have to be careful. So if you summarize all this data, we see a reduction in atrial fibrillation, we see a reduction in mortality, but it's not significant for low bias studies. And if we see all the studies also significant for low bias studies, we see a reduction in renal replacement therapy. So there was a more recent meta-analysis comparing vasopressin with catecholamines versus catecholamines alone, focusing on renal outcomes, and also it was not only vasopressin but also other analogs, and you can see here the incidence of acute kidney injury, so renal failure, was lower with the use of the combination with vasopressin, and also the need for renal replacement therapy. And then there was this meta-analysis by Russell from the FAST study, who showed nicely that if we compare drugs that increase the heart rate during septic shock, there is a trend to increased mortality. And then we look at studies also like beta blockers, like short-acting beta blockers like esmolol or vasopressin, you see a trend to a reduction in mortality. So maybe heart rate is something we have to take care of in septic shock. And we know more norepinephrine can also, although slightly, increase heart rate. It's in the guidelines of the Surviving Sepsis campaign since 2015 to add vasopressin up to a dose of 0.03 units per minute, or epinephrine if you want to raise the mean arterial pressure, but also to reduce the norepinephrine doses. But in the recent Surviving Sepsis campaign update published only a few weeks ago, we see similar information, because there was this effect that in the less severe septic shock, we see even a benefit in survival when you add the vasopressin to this patient. Although a subsequent study failed to confirm this, they recommend still to use it as adjunctive therapy up to a dose of 0.03 units per minute. So that's in the most recent Surviving Sepsis campaign guidelines. And this is our local protocol. So when we have a patient in refractory shock, and we have adequate fluid resuscitation, and we know that we have enough cardiac output, we can do PICO, ultrasound, passive leg raising test, lactate levels, and so on. And we have started steroids already. We started a little bit earlier at 0.1 micrograms per kg per minute, the steroids. At 0.25, we start with argipressin. And we build up in steps of 20 minutes. So we increase by steps of 0.01 international units per minute. And when the blood pressure is okay, we stop. And if it's not okay, we have to increase the norepinephrine levels. We go to the higher dose up to the maximum of 0.03. And when the blood pressure is sufficient, we gradually reduce the argipressin levels. However, we only do this when we are at the norepinephrine level of 0.10. Because if you start it again or start tapering it again at 0.25, you get rebound hypotension in many patients. So it's recommended to reduce the norepinephrine to rather very low levels before you start to taper argipressin. And if you need more, of course, you can increase the argipressin dose. What is also important to notice that in patients with right ventricular failure or pulmonary hypertension, it's also a nice drug to use because there are no vasopressin receptors in the pulmonary vascular system, so it does not increase pulmonary hypertension in contrast to norepinephrine. And this is a meta-analysis on discontinuation. Should you start with the vasopressin or start with the norepinephrine? And you can see when you start stopping the norepinephrine first, you see more hypotension. So it's important to go to very low doses of norepinephrine or even stop it. We don't do that because norepinephrine, of course, is a little bit less expensive. And here you see an example of the vasopressin registry we've started in the Netherlands. So there are several sites putting all the patients in our registry, and you see the cumulative data here of the patient. So on the y-axis, the cumulative norepinephrine doses, and then we start the argipressin in orange, and you see that we can reduce the norepinephrine dose. And you see this downslope of the norepinephrine curve, and it's even more than the vasopressor dose. So it seems that we also solved this vasopressin deficiency maybe. But you also see that when we taper the norepinephrine too early in the late phase, we see a rebound. We have to increase norepinephrine and we have to increase argipressin. So I recommend to go to very low dosages of this of norepinephrine before you go down with the argipressin. And we started this registry in the Netherlands At the moment, we have 10 sites in the Netherlands and 1 in Italy, and we want to learn more about the practicalities of the use of argipressin. So about, I can work to this, about the efficacy, the safety, the complications, the average dose, the tapering, etc. So that's the reason that we want to do a cohort study of 200 patients. And if you are interested, you can contact me, and then we can work together on this registry. At the end of my presentation, I'd like to show you a few COVID-19 patients with refractory shock. It's not very common. We treated over 150 patients with COVID-19 pneumonia, and 3 of them had refractory shock, defined by this dose of 0.25 micrograms per kg per minute. You see a female of 63, a male of 75, and a male of 42. And you see that the duration of argipressin was very variable, from 2 to 19 hours. And some patients went up to the highest dose, so 1.8 international units per hour, and 1 patient stopped at 0.6. So if you take the first patient in the left panel down, you can see after we started the argipressin in green, you see a rapidly decline of the need for norepinephrine. This was a successful case. The patient was still alive after 6 months. So in the middle panel, you see another pattern. So we built up the argipressin dose. We saw an initial reduction in the norepinephrine need in this patient, but then norepinephrine levels went up. But this patient was very poorly able to be ventilated, so in prone position, in severely hypoxic. Oh, I go back to this. And finally, this patient died. So this was an unsuccessful case. In the third panel, you see a patient, we had high levels of norepinephrine. We increased the argipressin to the highest dose we used, so 1.8 units in this patient. And what you can see that it took a long time for the norepinephrine to go down, and we needed the use of argipressin for 19 hours, and then we could taper it and we could stop it. This was also a successful case, so we had a survival at 6 months. So it's a limited experience because it's not so common in our hands to see refractory shock in COVID-19 patients, but I think this pattern of response resembles what we see also in other patients with septic shock. So if I summarize our experience, I would like to say that high-dose norepinephrine or a norethylene monotherapy may not be the best. So catecholamine-sparing effects can be achieved by treating the patient with vasopressin, and also it helps for vasopressin deficiency in sepsis. It may reduce atrial fibrillation, AKI incidence, and the need for renal replacement therapy. And well, the jury is still out about mortality. But maybe if we started a little bit earlier, we see also an effect on mortality. I showed you our practical protocol we use in the Netherlands, and that we also have started the National Investigator-Driven Registry. I've showed you that in COVID-19 patients with refractory shock, although we have limited experience, we see rather similar responses compared with other patients with septic shock. With that, I'd like to conclude. Thank you for your attention, and I'm happy to take your questions in the Q&A session. Thank you.
Thank you, Professor Van Zanten, for the great overview about vasopressors in COVID-19 patients. Thank you very much.
You're welcome. Thank you.
Thank you very much. Was a great update on this topic. Very, very interesting. And I think, in fact, the management of shock means trying to find solutions in order to support the autonomic system to maintain homeostasis, to defend this inner self that define us. And we have these new possibilities now beyond the oldest but goldest catecholamine that we have used for almost 1 century, since the beginning of 20th century, when when Salter described them, and after that they were introduced in clinical practice. In fact, this evolution is parallel with change of concept regarding the autonomic system. This autonomic system that was recognized very early, in the early times, by Greek physician and philosopher Galen, and described by Langley at the beginning of the 20th century, was described with two parts, as we know, sympathetic and parasympathetic system. But now we have this extended autonomic system concept that includes in this complex system of reaction not only these two parts, but also autonomic neuroimmunology, inflammasome, arginine vasopressin that we have discussed today, hypothalamic pituitary adrenocortical axis, renin-angiotensin aldosterone system. And now, today, our speakers presented one option, one line of this complex network that interact in order to maintain homeostasis. I will have a question for the speakers. You presented very well the management of septic shock, and the target that is specified in the Surviving Sepsis campaign guidelines is a medium MAP of 65. What about the target of MAP in critically ill patients? Because we know there are discussion if we should keep MAP at 65 as the only target, or we should adapt it according to different criteria.
So I'm happy to comment on that. You know, I think that your point that one size fits all arterial pressure goal, it's probably not ideal. We know that particularly for patients with pre-existing hypertension, if you target a higher arterial pressure goal, you can have a lower incidence of kidney injury. That was the sepsis PAM trial. Unfortunately, it's counterbalanced by increased toxicity from your vasopressors. So you have to decide which of those two outcomes is more important. But also on the opposite end, the recent 65 trial, which was published last year in JAMA, showed that in patients that are older than age 65, who often have low diastolic pressure due to the changes in vascular stiffening that occur with aging, that actually you can do well with a MAP between 60 and 65 as opposed to greater than 65. And it really all depends on what the patient's baseline blood pressure is. So certainly if you have a patient who is chronically hypotensive for one reason or another, there's no reason why during sepsis you'd have to raise their blood pressure higher than their baseline. Likewise, if you have a person who has badly uncontrolled hypertension and is used to very high arterial pressure, it's very likely that if you allow their arterial pressure to be, you know, quote unquote normal for the population, that they're actually going to have hypoperfusion.
Yeah, so maybe I can add to this. What is also interesting, of course, we focus on short-term effects. And of course, our main goal then may be just the blood pressure to save the patients in the ICU. But we also have to consider the late effect on cognitive decline or other aspects of recovery. And there is not much information. What is also interesting to see that maybe the drug that was given before ICU admission for hypertension also makes a difference. So it's maybe also not so that hypertension per se should lead to higher blood pressure, but maybe also on what kind of drug the patient was before in well-regulated hypertension. So I think it's much more complex, but how should we know during our treatment? In our hands, of course, we will lower the blood pressure a little bit more in those patients in a refractory shock. So when your patients need extremely high doses of epinephrine, we will not aim for a mean arterial pressure of 80 or 85. Of course, those patients you go to 65 or 60, and you have to balance the need for vasopressors to your mean arterial pressure. So I think most patients in refractory shock will not have very high mean arterial pressures already, but it's a good point.
I also think that if you see that your patient, for example, is having signs of poor perfusion at a MAP of 65, it's reasonable to ask yourself if a higher MAP might help. For example, if you see low urine output in a previously hypertensive patient when you're targeting a standard MAP, oftentimes I'll do a challenge. I'll raise their MAP to 80 or 85 like the sepsis PAM trial. And if their urine output improves, then that gives me some indirect evidence that their body might be looking for a higher blood pressure because of the different autoregulatory set point.
I have two other questions for you. One is about what do you think about adding dobutamine for the vasopressors? And in the case of atrial fibrillation or pulmonary hypertension, what is the opinion of the experts in starting a red vasopressin as the drug of choice?
So two separate but important questions. So in my experience, dobutamine is the most effective of the beta-adrenergic inotropes for raising cardiac output. And part of that is because of its vasodilator properties that reduce cardiac afterload. It also tends to couple with the beta receptors a little bit better. The problem is that the vasodilatory effects of dobutamine can be a big problem when someone's already vasodilated. And the dose response of dobutamine as it relates to blood pressure can be highly unpredictable. So a patient might tolerate a low dose, but then have worsening hypotension with a high dose. So although if I have a patient who clearly has low cardiac output aggravating hypoperfusion, I definitely will consider dobutamine. If they're predominantly vasodilated, I might start epinephrine instead. And in fact, in my experience, low-dose dopamine's predominant clinical value, this is 2 to 5 mics per kilo per minute, is as an inotrope, potentially as a substitute for dobutamine when dobutamine causes vasodilation. So I tend not to use a lot of dobutamine in sepsis, but if it's a mixed shock state, it's definitely reasonable to try. Now, as far as the more complex questions about arrhythmias and pulmonary hypertension and vasopressin, so I would not say that I use vasopressin as my first-line vasopressor very often, if ever. That being said, I'm much more likely to use it early when I have these secondary indications like rapid atrial fibrillation or pulmonary hypertension. One of the challenges is that we do know that in patients with uncontrolled sepsis, starting norepinephrine and improving their blood pressure can actually bring down their heart rate. And that can be true in patients with and without atrial fibrillation. And so I think that it's very reasonable to start with norepinephrine, but certainly if it looks like the heart rate is going up as the result of norepinephrine titration, that would be a very nice cue to add on vasopressin early. The whole pulmonary hypertension issue is very complicated because we're really talking about very limited physiologic studies, most of which are in animals and a few of which have been in people, but really the amount of evidence showing a difference in outcomes with pulmonary hypertension with or without vasopressin, to my knowledge, is extremely limited. And in many cases, raising the blood pressure to allow an adequate perfusion pressure to the right ventricular myocardium is far more important than those effects on the vasculature. But that being said, certainly when I have an RV failure situation, cor pulmonale, I'm much more likely to use vasopressin early as opposed to late.
Yes, I fully agree that, so we don't use dobutamine much in septic shock, even when there is like a limited cardiac function, we use phosphodiesterase inhibitors because they don't have this negative effect of increasing heart rate. And with respect to pulmonary hypertension, it's done. I know from several sites in the Netherlands that they use like vasopressin more as a first-line treatment, but it's more in cardiac ICUs and not in septic shock patients. So I fully agree. I would start with norepinephrine in septic shock and do fluid resuscitation, etc. And then maybe you want to go earlier because some units use vasopressin at a level of 0.5 or even 1 microgram per kg per minute. And I think that's rather late. And when you have a patient with right ventricular failure or pulmonary hypertension, we tend to do it earlier. So maybe you start at 0.15 or 0.2 already, considering it for this reason. But I agree that the evidence is very limited in this area.
Yes,
another question. Okay.
Please, Ludmila, please.
No, please, Professor Dobutamine, go ahead.
Ladies first, please.
The other question is about Terlipressin, Glipressin. Everybody wants to know our experience. In the case that we don't have vasopressin, if you would recommend the use of Terlipressin.
So I'll be honest, I've never actually used Terlipressin, so I'm going to defer to my colleague here if he has more experience than I do.
So we used it, we use it several times as a bolus. Then you see a rapid effect, but you also see severe vasoconstriction and side effects. And when you use it as a continuous infusion, you have the problem that you have a drug with a long half-life as a continuous infusion. That's not, from a pharmacokinetic perspective, not very helpful. And then it's better to have vasopressin or angiopressin because it's more titratable, it's more on-off. And of course, if you don't have it, you can try it to use it. But in our hands, it was more difficult to find this balance in titrating your catecholamines and your vasopressin analog. So if you don't have other drugs available, of course you can try to do it, but be careful of not accumulating the dose during a continuous perfusion. And when you use it in an intermittent fashion, you see that after several hours you have to repeat it to give a bolus, because then your blood pressure goes down, your norepinephrine needs go up. So it's a little bit more difficult to do. And it's my impression, although the literature is very limited on this, because there are not much of head-to-head comparisons between Terli and vasopressin, that the side effects are a little bit more with Terlipressin. But well, it's not based on much literature to say that. But we had patients with severe ischemia of fingers, nose, and we don't see this so much with vasopressin. It's actually very rare, and we have treated maybe over 100 patients in the last few years. But
yes, it's true. We have the opportunity to use vasopressin in Romania, and we have quite a good number of patients, and we do not have these ischemic peripheral lesions. Another interesting question from the audience, there are a lot of questions. I'm afraid we will be not able to answer to all. Another question, insulin. Insulin has been shown to exert positive inotropic effects in several in vitro and in vivo models. Could it have a role in refractory shock?
Insulin?
So that's an interesting question.
Insulin.
So I know that there is a literature using hyperinsulinemic euglycemia, where you administer a glucose infusion and an insulin infusion simultaneously for example, beta blocker overdose or calcium channel blocker overdose. Again, the risk of toxicity, hypoglycemia there is very, very high. I've personally not used that strategy for septic shock, and I'm not personally aware of any data. It is a very interesting question. Again, as far as using it as an inotrope versus using it as a vasopressor, I think those are two different things. My suspicion is that strategy would probably be very hard to use in clinical practice with the potential risk for life-threatening hypoglycemia. But again, it's in the toxicology literature, certainly for certain drug overdoses.
Yeah, to add to that, I think that from a metabolic perspective, of course, most of those patients will receive insulin because they're in such an insulin-resistant state that many of them need continuous infusion of insulin. But we only go to the normal levels of glucose and not giving more glucose, and because most of those patients have a lot of endogenous energy production, and also there's maybe some mitochondrial dysfunction. So it's just, can you expect that it will help much in this metabolic, very difficult situation? So I'm not sure whether this will be very helpful. And I fully agree with Jacob that the risk of hypoglycemia, when you're in shock and you also have hypoglycemia, this will be trouble for the brain in the future. I'm very sure about that.
Yes, in fact, we all know that we use for a period of time the tight glycemic control with higher doses of insulin, but now we do not, they are no more recommended in the guidelines. Yes. Ludmila, did you find another question? You are muted. You are muted.
They are asking about that in Africa, they have good experience with epinephrine, without arrhythmias, without increasing lactates, and they are hypothesizing that they are treating younger population. What do you think about this? Epinephrine in septic shock and different pattern and profile of adverse effects depending on the population.
I suspect that they're absolutely right. Certainly when we're dealing with the population that I care for, which is patients who have underlying cardiac disease, myocardial ischemia at baseline, cardiomyopathy, those patients typically don't tolerate high doses of epinephrine because of their cardiac toxicity. We do know that the metabolic effects are probably benign, and they are only transient. Again, I didn't focus on this, but one of my slides showed that really those effects last for about 24 hours and then the body adapts. So certainly if epinephrine is the only catecholamine you have available, it's definitely not wrong to use, especially if you're looking at a population that's not at high risk of cardiac toxicity. Now I want to emphasize though that there's a big difference between septic shock and cardiogenic shock here, because when you have patients with cardiogenic shock, there's a couple of studies that now are showing that epinephrine is potentially harmful. And so, again, the type of shock definitely drives the adverse event profile.
Perfect.
Yeah, thank you. One question is, if vasopressin is approved by EMA, European Medicine Agency, yes, of course, as we can use it in our medical practice. There are questions and there are people from the audience asking for your protocols. So I'm sure we will find a way that they can access the presentation and to have access to complete protocol that you're presenting during your speeches. And finally, we reach the time limit of our webinar. There are a lot of questions put by audience, and I'm wondering if it will be not possible to answer to them after the end of this webinar, so they can access the answers. I ask you if you agree to try to answer to several questions after we close the webinar.
Sure, I'm happy to help.
Yeah, okay. Yeah, that's okay. Or you can send me an email. My email address is in the presentation.
Same is true in my case. I'm happy to answer emails.
I want to thank you very much for your contribution for this great webinar. It was very interesting. It was a pleasure to be together, even in this online way. I'm sure it will be even greater the next session when we hope to be again together. Doesn't matter in which continent, one of the three continents that we represent now. I congratulate you. Thank you, Ludmila. It was
thank you very much.
A pleasure. And thank you to the audience. All the best.
Thank you.